All right. Good afternoon, everyone. Welcome to Pitch'em. We're hoping to close our conference out with a bang. We have a live digital health innovation competition featuring groundbreaking solutions in healthcare. We have with us three exceptional founders who will pitch their innovative solutions today. First, let me introduce Longsha Liu, founder of Vita Innovations, developing an AI-powered triage companion, providing personalized decision support in crowded emergency department waiting room settings. Next up, we'll have Dr. Kathy Che, founder of CyrenCare, a platform designed to optimize emergency department workflows, streamlining patient care in critical situations. Lastly, we'll have Dr. Natalia Kosla, founder of Simbie Health, a personalized healthcare platform that uses AI-powered tools to help patients manage chronic conditions and stay on top of their health. Each participant will have about 7 minutes to present, followed by a few minutes of questions from our expert panel of judges. Our judges will evaluate the pitches based on criteria such as the team's strength, the business model sustainability, market advantage, evidence of traction, and the potential to improve care and health equity in the emergency department. At the end of the competition, they'll share the decisions on the winning pitch. Now, let me introduce our panel of esteemed judges. We have Dr. John Dayton, a physician entrepreneur and leading advocate for medical innovation and recent graduate of the Stanford Emergency Medicine Innovation and Design Fellowship Program. Welcome, Dr. Dayton. Next, we have Dr. Nisha Mehta, a radiologist, keynote speaker, and advocate for physician empowerment, burnout prevention, and financial literacy, who leads the physician side gigs and physician community groups with nearly 200,000 physician members. We have Jamie Tremaine, currently serving as entrepreneur in residence at the University of Toronto. Jamie steers early-stage med tech companies towards successful commercialization. Welcome, Jamie. And we have Shawn Fojtik, who holds over 100 issued and pending patents and is the co-founder of multiple health tech companies, driving innovation in cardiology, radiology, and more. Without further ado, let's begin with our first pitcher, Longsha Liu, and give him a warm round of digital applause.
Good afternoon, everyone. My name is Longsha. I'm the CEO and co-founder of Vita Innovations, where we're transforming ER wait times into lifelines. The ER is often considered the front door of the hospital, that for an increasing number of people constitutes their first initial experience with the health system. And yet for many, this becomes an experience riddled with frustrations and inefficiencies. So much so that the AMA wrote in a letter to President Biden just 2 years ago that our ERs are on the verge of breaking beyond repair. Today, over 90% of ERs are reporting overcrowded conditions that, when compounded with the exacerbation of nursing shortages, now exceeding 30% in some hospitals, is leading to critical gaps in patient care. Take, for example, the triage experience, which has shrunk to just 91 seconds on average with a triage nurse, of which there's just 4 primary inputs: name, age, sex, and chief complaint. From there, with only a few subjective questions, a singular triage score from 1 to 5 is determined that will dictate how long patients wait before receiving the care that they need. Because of this lack of information, 1 in every 3 patients are wrongly assigned a score, leading to delayed and more costly care, as well as increased risks of deterioration and mortality. But this problem only scratches the surface for us of how systemic this issue truly is. And so over the last several years, my team and I brainstormed with over 300 ER administrators and providers to explore what it means to build a truly efficient ER. We discussed elements for improving triage accuracy and quality of care, expanding clinical capacity for our nurses and physicians, proactively addressing discharge delays to reduce the length of stay, and addressing the patient's full set of critical needs to reduce their likelihood of readmission. On a fundamental level, this seems like mere idealism and naivety, because to acquire the comprehensive context it takes to provide better care, safely shorten length of stay, and reduce readmissions requires the further sacrifice of the very resource that providers don't have enough of: time. But at Vita Innovations, we don't believe this has to be a mutually exclusive process, because in the majority of our cases, our patients have the time that they're waiting in triage before even seeing a nurse, the time they're waiting in the waiting room or hallways to get care, and the time they're waiting in the bed before being discharged. That's time we can transform using technology to fill the necessary gaps of context that we need to provide safer, faster, and smarter emergency room care. That's why I'm proud to introduce Emergent AI. Our platform, accessible via tablet, mobile device, or in the setting of telehealth, an automated phone call, designed to meet both patients and clinicians in the areas of the ER where they need it the most. Here's how it works. When a patient walks into the ER, our virtual assistant facilitates check-in and triage by pulling relevant electronic health data and filling gaps regarding the patient's history of present illness, medical history, family history, and medications to send to the triage nurse. On the hospital's EHR, nurses then receive a comprehensive patient summary, score assessment, and recommendations for next steps in care, increasing their cognitive capacity, triage accuracy, and code status awareness through having more context and insights. But our work doesn't stop there. To reduce patients' length of stay while also coordinating care beyond just the ER, we've transformed the hours of unutilized wait time to proactively interface with patients to capture information regarding their social determinants of health, mental health, and goals of care. Lastly, to reduce the likelihood of readmission, we created an automated way to match patients with social drivers of health needs with eligible food, transportation, and housing services. Our beachhead is a $13 billion accountable care-based ER market that is historically overcrowded and understaffed, where our business model utilizes a B2B SaaS approach coupled with a one-time implementation fee as we customize a white label solution unique for each customer. Moreover, we stand to provide each ER with a projected return on investment of $8.5 million annually through improving patient and nursing experiences, as well as reducing key hospital metrics of clinical deterioration, length of stay, and readmissions. Unlike our competitors, we are the only platform that targets a full end-to-end ER journey. We offer a highly customizable solution that aligns with the operational realities and unique workflows of every hospital. Moreover, through our partnership with InterSystems, where we're the recipient of their investment grant, we're able to seamlessly integrate into all major EHRs. Lastly, we understand the importance of safety and quality in healthcare technology and have built a state-of-the-art AI governance model. In fact, we're sharing some of these findings real soon with the broader public with our emergency medicine-specific benchmarking study for large language models. And we're delighted to share that our technology is coming to Weill Cornell Medical Center in New York, where we're conducting a 385-patient study, while also further engaging our stakeholders within the Stanford and Australian health systems for additional potential deployments. To drive this mission, we've built an incredible team of seasoned healthcare professionals, leaders, and technologists, with combined decades of experience developing impactful healthcare solutions for health systems and pharma. For the investors in the crowd, we are raising $1.5 million to fund our technological scaling, team expansion, and clinical deployments over the next 24 months. And for those who see a use case of our technology in your health system, please reach out, as we love to talk more about how we can help expand context for your patients and provide proactive planning around discharge, all centralized on one platform that minimizes trade-offs and maximizes care, efficiency, and capacity in ERs. Thank you very much for your time.
I will invite our judges to ask some questions to Longsha and Vita Innovations.
Thanks, Ron. I had two follow-up questions. I'm interested to learn more about your pilots, how you're setting those up, and what kind of data you're gathering. And then the other question I had is about a lot of triage right now is based on vital signs. Just curious how those vital signs are integrating to these questionnaires you're asking the patients.
Yeah, these are fantastic questions. So with regards to our clinical trials at Cornell, we're enrolling 385 patients where they're going to have an RA, so a research assistant, come in with our technology that they walk through for a focused period of 10 minutes. And this is during the time that they're already waiting in the waiting room. So, there's already currently nothing being done for them as they're waiting. So we're just capturing more information. And then proactively, we're using a retrospective analysis. So we're not directly intervening with any nurses' clinical decisions up front, but rather we're doing a retrospective analysis with a panel of nurses afterwards, where basically you do the side-by-side comparison of this is the current triage notes that you would have today in your current workflow. These are the notes you would have with us. And we're measuring that sort of in terms of action responses. Like, are there things that we picked up on through those 385 patients that we could activate subsets or stroke codes? Because oftentimes it's just additional questions we're asking that aren't just the routine ones where you're building the rapport with patients that we're suddenly finding out, oh, they came with infection and then they've been experiencing some facial droop or muscle weakness. Right? There's those subtleties that by having a true conversation, by engaging in dialogue throughout that entire encounter, we can pick up on it. And those are the positives that we want to look for. With regards to vital signs, yes, vital signs are still a very, very important part of triage. And right now, we initially set up in our technology a way to connect any Bluetooth device, right? If you're wearing an Apple Watch or Fitbit, we can collect and monitor those vitals. Unfortunately, right now, they're not still technically clinically usable. I imagine as time goes by, like Apple's AirPods just got, I think, designation as a hearing assist, right? I think we're going to see more and more of that. And then hopefully the goal is then even on one centralized platform, you don't need a separate pulse oximeter. We can literally just be using what already exists. But right now, we can't substitute that part. So nurses will still have to go through the usual parts of vital collection. But that being said, we are in conversation with a company called Simbie Health that is doing the sort of vital triage, where we can be the complementary sort of software to ask patients more questions.
This is Shawn. I got a question. First of all, a great first presentation to kick this thing off. Where does the 1.5 million get you? The use of funds?
Yeah, the 1.5 million gets us to, first of all, we want to hire a few more nurses and translators, because part of the value prop of, a technology like this is anyone who comes in speaking Mandarin or Spanish, right, we can engage with them. But it does require a sizable amount of time for us to train and ensure that we have the right human in the loop. So for the first sort of, couple hundred hours where we're deploying our technology, we want always either a nurse and translator in the call so that we can verify for quality assurance. And the major components for us is, we have a lot of expansions plans in terms of technology. So there's a lot of software costs associated with that, cloud management fees, interconnectivity and interoperability fees. Those are just the primary components where, we can enter the first 5 to 6 hospitals that we want to partner with, get that data over the next 2 years to really de-risk, prove all the ROIs, and then take it to scale.
Hey, Longsha, it's Nisha. Oh, sorry. Did you want to go?
Go ahead. Yeah.
Okay. I was just going to ask, so I think, like I said, or like everyone said, you did a great job with sort of presenting the value proposition. In terms of your, like, the uniqueness of what you were building and whether or not, how replicable you think it might be within an existing EMR, like, because presumably your go-to-market is going to include selling some sort of subscription-based model to hospital systems, which we all know that that process can be very long. But in getting those people on board, right, what incentive are they going to have not to just, ask their EMR? Like, what happens if an EMR is just like, oh, we're going to develop this for all of our hospital systems, and that's going to be a feature of our EMR? Like, what's unique enough about
I think with any... Yeah, a few components. I would say, like, of course, with any digital health play, right, the fear is always, oh, what if Epic comes in and takes it? Because Epic showroom, right, clinicians are constantly telling Epic what they want and they build in. Where I think the niche is for us is that these are like very tiny elements that you need to capture throughout the entire process, right? It's one thing if you just create an entirely new user interface to capture that data on a centralized EHR. It's entirely a different aspect to intervene a little bit during the triage, intervene a little bit during the waiting room period, intervene a little bit more into the social determinants of health. And yes, ideally, everything should be interconnected, and Epic can drive that charge, but there's going to be a long delay. Right? And inside that delay, that doesn't mean we shouldn't be doing anything. And our ability to integrate into Epic, to integrate into Cerner also kind of de-risks for hospitals. And I would say on our technological side, we have spent a lot of time and a lot of money on ensuring a really robust sort of quality improvement system. So we have a model that is specifically tuned for emergency department chief complaints, meaning that on the back end, we used a cascade model that routes to the best performing model. We have our own safety checks throughout the entire process. So there's definitely reproducible elements when it comes to software, but ultimately in terms of the grand scheme of everything we're trying to capture and what we already achieved to date, I think those are distinctive edges for us.
Jamie here. I guess I'm curious about how that 8.5 million ROI breaks down and also what it means to be end-to-end as a solution.
Yeah. So I'll first address like the end-to-end solution aspect. Oftentimes we're seeing these point solutions in ER that don't go far, right? Because it's too many points of unique risk that we have to take on, right? Having a risk in triage, having a risk in terms of the waiting room and in discharge. So what we're really trying to capture is it's a central platform for patients to engage throughout their entire journey at the ER. So from the instant they step in, they're using our technology to do the initial triage onboarding. We don't need to create a separate application for them to have to ask the surveys questions about travel history, mental health, social determinants of health. We also don't need a separate solution there to connect them to resources on housing, financial, or food insecurities. How the 8.5 translates, a lot of these are basically, we're still de-risking through the studies that we're doing with Cornell and then a few other sites very soon. But we're really looking at, how are we doing in terms of reducing left out being seen rates? How are we doing in terms of reducing the bed, reducing length of stay and bed turnover rates? And a lot of these are, we identify issues in discharge delays. We try to proactively do that up front. So we're not waiting until right before that patient's ready to leave. We find out they don't have transportation, right? We're finding that out at the beginning of their visit so we can already begin coordinating. Similarly with case managers and social workers on any other needs.
Thank you.
Wonderful, everyone. Longsha, thank you so much for your pitch. And
Thank you for this opportunity.
Of course. And Longsha is a medical student as well, who's so accomplished. To everyone out there, it's never too early or too late to get involved in this space. Thank you, Longsha. All right. Next up, we have Dr. Che with CyrenCare.
Hi, everyone. Thank you so much for the opportunity to share what we're building with you because we are building for you, the emergency medicine community. So over a decade, when I was practicing as an emergency medicine physician, when I started the medical history taking process, a process so critical in diagnosing patients over any lab or imaging, I start with, what brought you to the emergency department? And I realized that it was really frustrating patients because it was the 10th time someone was asking the same question. And I realized how fragmented emergency medicine communication is. We're basically putting patients on a conveyor belt of repetitive questions. They're repeating their story over and over again, and everything is vanishing in thin air. Which is ironic that we have these inefficiencies because providers are seeing multiple patients at once, interrupted 10 times an hour, have the highest burnout rates, but we're spending 1/3 of our time physically asking questions to collect information, whereas patients are waiting hours feeling left in the dark. And from patients waiting long hours and just leaving before they're seen, $4.5 billion of revenue potential is just walking out the door. So we clearly have a supply and demand mismatch of limited number of healthcare providers struggling to take care of these patients, but also a mismatch of time where patients are just waiting and healthcare providers are busy. So what if we use this wasted time to help lift the burden for healthcare providers, more specifically by capturing patient-generated HPI reports and provide them to healthcare providers? So instead of starting from a blank sheet, they have a starting point in the medical history taking process, empowering patients to contribute to the medical history taking process. So imagine a QR code at the register or the waiting room where patients would use their own mobile devices to answer questions that providers would have around their symptoms, and we translate it into clinical terminology, into a clinical context and send it over. We've based our questionnaire on the emergency medicine textbooks, cover more than 130 symptoms, had 6 other emergency medicine physicians validate the questions so that we make sure that we ask all the right questions that any good emergency medicine physician would ask. We've collaborated with a health literacy expert to make sure the language is easy for patients and understandable. We also offer our service in 30 different languages and provide CMS quality verified translations so that we can reduce the translation-related delays. And we enable providers to text patients to collect additional questions or notifications or forms. And one common example is a physician, after seeing a patient, coming back to the computer, starting to document, realizing that they forgot to ask what pharmacy that the patient is using. So instead of having to walk down the hall for a minute or two, if you have a large footprint, and look for the patient, which obviously is in the restroom, grab an interpreter, get that one question, come back, interrupted 3 times on the way, providers can text patients and get the answers back on their computer while working. And we display this information with EMR integration with Epic and Cerner, but we also provide a widget that any emergency department can use from day one. No heavy lifting from the IT team during the free trial, no upfront cost. Just set a QR code at the register and download the widget and you're good to go. And that widget sits on top of any EMR system. It's like the size of a quarter, and with one click, they can see the reports, and with another click, they can throw the reports into the free text without having to jump around multiple pages. And they have this widget to use while we do the integration. So what really sets us apart is our focus in emergency medicine and our clinical depth. And while other vendors are focused in outpatient care or helping the front desk with the administrative tasks, they do collect some clinical information, but it's mostly around the patient's past of medications or what brought them to, or past medical history or allergies. Meanwhile, we focus on helping our emergency medicine healthcare providers collect the medical history by capturing patient-provided triage reports or HPI notes, and really help with the clinical tasks. Another way that we're building differently for emergency medicine is acknowledging the fact that one flow doesn't fit all. So this is an example of an early partnership where we look at the flow of how each stakeholder is collecting information from patients, and we mirror that exactly with our no-code tool so that the emergency department has full control around what questions are being asked, how they're being asked, and how it's generating a report. And that goes with the clinical content as well. So while we provide the clinical preset of the questions, the providers have full control and transparency around what's being asked and how it's generating a report. So instead of that conveyor belt of fragmented communication and repetitive questions, patients go through one streamlined questionnaire and we generate a report for each role in the patient flow. So for instance, the register gets information around insurance and consent forms, new patients, triage. If they're using any dot messages, we can mirror that. If they're using any Epic Smart Forms for nurse-initiated orders, we can mirror the content there, and we can help with risk assessments, etc. And for the healthcare providers, the patient-provided HPI, if there's a community health worker collecting social determinants of health, we can also do that as well. And by doing this, we help healthcare providers save 2.5 minutes per patient, reduce the door to provider time by 25%. And by reducing the left without being seen rates, by engaging patients while they're waiting instead of just leaving them in the dark and expediting care, we help an average emergency department in the United States capture $180K per year of revenue. And we have an ROI calculator on our website, so each emergency department can put in their own metrics to see their own ROI. We initially have a bottom-up TAM of $500 million. But as we expand to be the go-to platform for the emergency medicine vertical, starting pre-hospital, continuing post-hospital, and as we're tackling a global problem, our market expands to a $122 billion TAM. CyrenCare is designed by an emergency medicine physician, built by the co-founder of ZoomInfo, and we have meticulous housekeeping around finance and operations. So we're ready to make some changes in emergency medicine. We had a pilot where we looked at the patient experience, and what was really commonly brought up was that patients were reassured that they were able to organize their symptoms before encountering a white coat physician. So there's this preconditioning effect for patients. And compared to the status quo, they've expressed that it was much more efficient and had better communication. So 2 months post launch of our MVP, we closed our first paying pilot hospital, a hospital in Oregon with an annual emergency department volume of 20K. We've also received a letter of intent and research proposal from Enterprise Hospitals. And we're now raising $1 million to run for 18 months, and we've closed 30% of our round. We're focusing on small to medium-sized emergency departments with high left without being seen rates. So if you're in the audience and you have a waiting room situation, please contact us. And in parallel, we're also partnering with academic medical centers to build the evidence and, expand our product to be the go-to platform for emergency medicine. Thank you. I'd love to entertain any questions. I think.
Yeah. What kind of receptiveness have your customers had to your ROI proposition so far?
So the ROI proposition is based on previous literature of patient-reported symptoms and how that affected door-to-provider time and how that saved the provider's time. So it is a bit hypothetical. We are looking for partners to actually validate that. Is that touching your question?
It does. Thank you very much.
And my question's along the same lines. You mentioned wanting to work with academic centers and specialty societies. Tell me your goal there and what that would look like for your company.
Yeah, sure. So one of the research partnerships would be around EMS and emergency department communication and the handover and the missing data points around that. So that's a bit of an exploratory project. But when you think of what we're doing, we're helping healthcare providers collect the information that they need in a really efficient way, in a format that they're really, used to seeing. So that study is around that to see how we can bridge the EMS and emergency department. Another collaboration that we're talking about is more to the core of what we just mentioned and actually validating our ROI around, how much time we can save for the healthcare providers and the provider experience. The previous pilot that we had around the patient experience was very early in our prototype when we didn't actually have that connection to the provider side. And now that we have it, our next research pilot will be more around the provider experience.
Thank you.
I'm interested in sort of the same thing in terms of people that you've had test pilot this. How are those clinicians feeling about, is it actually eliminating their need to get that history again? Just because I feel like, clinicians kind of have a way of, there's a whole gestalt that comes with when you're taking a history that, if you're going to spend a lot of time reading what the patient said, you still may end up asking the same questions. So what kind of data do you have showing that they are actually taking less time in that process? Because with the advent of things like AI scribing, things like that, the documentation aspect of things will continue to be better. But is it actually, shortening the amount of time that they need to take history? Or are they spending more time reviewing things that they maybe didn't even want to ask? Or how, what are they saying?
Yeah, so thank you so much for that question. Out of full transparency, those are things that we do have to validate more. The previous studies that we've used for our ROI look at various types of patient-provided symptoms and how that really reduces the medical history taking process, and that is in the previous literature. What we are really mindful of, though, is what you've touched upon in your questions around how we present the information to providers. So if we present it in a way that it takes more time for them to review, yes, of course, it's going to probably do more harm than benefit. So we really are considering, how we present that information. As you can kind of see in the background that it's kind of into bullet points. and very much close to the mnemonics that we memorize in medical school, and like how we need to collect information around each symptom. So it's a starting point. It's never intended to be an alternative to medical history taking, because when we were doing that pilot with the patient experience, and I was seeing patients, how they were interacting with the platform, there are discrepancies in the definition of our terms. So for chest discomfort, dizziness, it can mean many things for a patient, but it means specific things for a physician. And for that purpose, we can never be like an alternative to anything. But when you think of how we interact with patients and ask questions and get answers, we have a similar thing. They don't tell us what we want to hear, but they tell us what they know, and we process that information. So we're reducing that time in just getting there and give you a starting point instead of having to physically ask those questions to get to that.
Wonderful, everyone. Any other questions from the judges? Okay. Well, thank you again, Dr. Che. We will move forward and introduce Dr. Khosla of Simbie Health for our final pitch.
Thank you.
Hi, everyone. Nice to meet you, and I'll just share my slides. Okay, is everyone able to see my slides? Great. So I want to introduce Simbie Health. Simbie Health is an AI phone staff agent meant to simplify patient intake, documentation, and follow-up. And we are backed by Y Combinator. In terms of our progress on raising, we raised and completed our round, so our round is now closed. So we're not actively accepting any investment, but we are constantly looking for folks that want to be design partners, that want to try out the platform, give us feedback, and generally work together. So, you know, one of the things, my background is I was a medical student at the University of Chicago, Pritzker, which is where this all began for me. And one of my biggest observations was that a huge amount of the time that I was seeing physicians spend with patients in clinical encounters was actually spent on data gathering. And it was the type of data gathering that I realized was often actually a dot phrase that could be given to someone as a questionnaire, questions that we're very familiar with in the HPI, history of present illness, like how long has the pain lasted? Has the pain moved anywhere? Have you tried anything for the pain? And I realized that, you know, physician-patient face-to-face time is maybe the most prized and precious time we talk about in medicine, but a huge amount of that short, often 15-minute visit was actually spent on gathering these formulaic, relatively structured questions. I ended up kind of in this observation going and asking tons of provider friends, of residents, attendings, and found similar themes coming up, that this comes at a massive efficiency and quality cost. For providers, we heard themes over the course of over 200 interviews, like there's very little time for me to focus on art of medicine, on deeper discussion when I'm spending so much time, you know, just reiterating, where is the pain? Where did it move? Is it associated with any other symptoms? The types of things that ideally should be there so I can dive deeper. And the types of things that only a human physician can do. Also heard themes like no time to plan before. What if I could see my HPI in advance? What if I could actually look some things up, you know, look up some papers, practice really good medicine instead of having to do it on the fly in the room. Documentation and pre-charting burden is something we're all familiar with, came up from providers. And then really this theme that we've talked about earlier in this pitch session of mentally translating physician to provider lingo. Patients speak in a very specific way. They notice certain trends. They might link their pain to something that happened a week ago that might be unrelated. And providers are looking for very specific other information. This translation gap is a lot to add on to the visit. From patients' perspectives, this results in repetitive forms that we've also talked about in this session, getting asked, where's the pain at the front desk on a form before and in the visit room. Online forms, we've heard from patient after patient that they would prefer, if they're going to do a history, over the phone while they're walking to the kitchen, driving. and rushed insensitive questions. What we've heard from patients is that this results in asking SDOH or PHQ questions quickly when they enter the room. Are you feeling symptoms of depression? Are you feeling down? Casually as someone clicks something into a computer. This is not a conducive way to ask patient questions. And from a practice perspective, quality and data compromise. So what we've done at Simbie is build out a voice agent that can actually have a discussion with patients before visits and after visits. A call log is able to be seen to see all patients that the conversation is happening with, and this is a clinically intelligent agent trained to ask it's kind of like your perfect medical resident that asks an ideal HPI, asks all the questions that one would hope with clinical context, and then generates a really high quality HPI that's already in your note pre-charted before you enter the room. So I'd like to show you an example of the intake call with our agent. Please let me know if there are any issues hearing this.
Hi, nurse practitioner. What brings you to the... Hello, my name is Simbie, and I am an AI nurse practitioner. What brings you to the emergency room today?
I have really bad sharp toe pain in my right toe.
First, can I please confirm your name?
Yeah, it's Emily Harris.
Thank you, Emily. Could you also provide your date of birth?
It's May 2nd, 1978.
Thank you. And could you tell me the sex assigned at birth?
Female.
Great. Thank you for providing that information. Now, you mentioned having sharp pain in your right toe. How long have you been experiencing this pain?
It started early this morning at like 5 a.m. and woke me up.
I see. Can you describe the pain in more detail? Is it constant or does it come and go?
It's constant. It's like worse when I move or touch it, and maybe a little less when I don't move.
Thank you for that information. On a scale from 1 to 10, how severe would you rate your toe pain right now?
It's really bad. It's like a 9, 8 or 9.
Thank you. Is the pain located only in your toe or
Just gonna jump forward.
symptoms or home remedies?
Yeah, I took like 2, ibuprofen pills this morning, and it hasn't really done anything.
All right. Is there anything that makes the pain worse or better, aside from what you've already mentioned about movement and touch?
No, I mean, basically I can't walk, so I haven't even tried that.
Understood. Have you noticed any other symptoms along with the toe pain, like swelling, redness, or fever?
Yeah, it looks kind of red and swollen. So pausing there, just to give a sense of what this agent sounds like. This is an agent that we've worked quite heavily on to work on the latency and its ability to respond in a human-like way, and specifically trained on a significant amount of clinical data and clinical encounters to make sure that it responds in such a way that is clinically informed. So after this encounter where the bot is taking an intake with a patient, it generates a clinically significant HPI, and it puts this information right into your chart. So this will be opened up as a note before the physician enters the visit. In an outpatient setting, this is happening the day before or a few days before, depending on the specialty context. And it's actually populating so that the physician can look through it, come up with a plan, and think of differential diagnosis and how they want to present education or anything else. The agent is also able to, according to the billing diagnosis, do a post-visit follow-up call, which I'll show a short version of right now.
A condition known as insulin resistance. Thank you, Emily. And could you please confirm your date of birth?
May 2nd, 1978.
Great. Thank you for confirming. Now, can you tell me what you understood about what happened during your visit to the emergency room?
Well, they poked around my toe and it hurt so bad, but then they told me, I have the same thing in my ankle, the gout.
I understand, and I'm sorry to hear you were in pain. Yes, during the visit, they aspirated your toe joint, which helped confirm the diagnosis of gout, and ruled out any infection. They started you on ibuprofen, 800 milligrams, which you can take 3 to 4 times a day as needed for pain. Do you have any questions about the ibuprofen or how to take it?
Okay, yeah. How long do I take those pain meds for?
You should take the ibuprofen as needed for pain, but it's important to not take more than the prescribed dose. If the pain is severe, take it 3 to 4 times a day with food or milk to help prevent any stomach upset. Once the pain subsides, you can reduce the frequency or stop taking it altogether. It's always best to discuss ongoing.
So that's just a sense of the post-visit call. So really, the value proposition here, like I mentioned, is patients having to tell their story just once, and then it's populated in the HPI, no multiple times. They have a conducive environment to ask sensitive questions. What we've heard from patients that they're actually, in some cases, more comfortable talking about mental health or SDOH issues to a robot where they don't feel judgment and they're not in a rushed clinical environment. For providers, we see an efficiency gain. So able to save 3 to 4 minutes per patient that we know is often spent on gathering this data and documenting the HPI, and able to plan before entering the room. So quickly going through our traction here, we are currently early. We are in a design partnership with a private practice in Chicago. That's a general medicine practice. That's our pilot. The integration at that practice, EHR that we're in progress is Practice Fusion. And our next targets are targeting physician-owned community practices first, where we can get started, get some reps under our belt. And specifically the practices we're in closest contact with are general medicine, ophthalmology, and dermatology. And the next goal would be to go to hospital and emergency department settings. The vision here is kind of as I outlined before. Happy to dive more into the TAM. And the team here, like I said, myself, I went to medical school at the University of Chicago. Prior to that was on a Fulbright scholarship over at the London School of Economics. And prior to that was at Yale for undergrad. Rachel O'Driscoll, which is our COO and co-founder, has spent almost 10 years in high growth startups 0 to 1 in clinical operations. And Natalia Perina, who is our CTO and engineer, was trained at Princeton. So we'd be happy for you to reach out. Like I said, our round is closed and we're not actively raising at the moment, but we're always excited to form partnerships and relationships with folks.
Wonderful. Thank you, Dr. Kosla, for another engaging pitch. I bring it back to our judges. Any questions you'd like to ask? John.
I'm interested in the rollout. Why dermatology and ophthalmology and then a hospital setting?
Yeah, it's a great question. And honestly, this is something that we're very open to discussing with folks and kind of like, having open conversations with mentors around. The reason for it is really, in our kind of outreach to getting people to get started and trying it. The first pilot partner, is kind of a relationship via a mentor. So we've been able to get started and really train on a large number of data. But in terms of the other settings, one of the reasons we found ophthalmology and one of the reasons we've been talking to those practices, a few of them a lot, is because we find that they have a highly structured, highly specific set of questions that they need to ask most patients in the beginning. It's nice because it makes it kind of stepwise to getting to a more complex history. For example, in a few of the practices we are planning to work with, they actually already have not the physician taking the history, but a tech who's separately taking the history via a pre-structured questionnaire or dot phrase. This creates a conducive environment for starting stepwise again for our bot to first kind of act in a more structured setting, and as it learns more to kind of go into more complex environments. But that's our current kind of logic, and I'm very open to kind of thoughts from other folks about how we should think about that journey.
That makes a lot of sense. Thank you.
Yeah, and this is Shawn. I love that you included the phone call there. What do you see as some of the biggest barriers besides competitive barriers to making this to getting to your next phase?
Yeah, it's a great question. So, at this point, probably one of the biggest barriers is just ensuring that as we're rolling it out, it's obviously an iterative process. So we're rolling it out, we're trying it with patients and with practices. And like I said, we're quite openly very early. So I want to be upfront about that we're in our design partnership right now. But, we're trying to be really mindful about how to take our evaluation criteria of the agent. You know, we have a whole set of criteria and logical algorithms for determining which outputs were good, bad, in between. And those are being sort of evaluated by physicians too themselves. So how can we make sure that that's iterative and that everything our bot learns is actually turning into new behaviors of it? That's always going to be the biggest thing when you're fine-tuning any kind of an LLM model. And that's really what we're mindful of, because obviously here we're trying to improve doctor-patient communication.
Great. Any other questions out there?
Yeah, maybe I missed this, but one thing I was confused by is the workflow. Does the call happen before the patient comes in, or how does that work?
Yes, it does. It's a bit varied per clinical settings. And like I said, we kind of have this stepwise approach where we're starting in outpatient community settings, actually, and like hoping to move into emergency department settings once we have more reps under our belt, considering that's a higher risk setting. So in outpatient community settings, how we are setting it up right now is that the agent goes down the list of patients that are coming in tomorrow on the schedule and calls each of them and gathers this and inputs this into a new note the day before.
Got it. Thank you.
What have you guys been doing about all the, like, I mean, there's a huge amount of data being generated, right? Who is making sure that that is all translated to the clinicians? And, you know, what if they tell the bot something that doesn't get relayed to the patient's liability, all of the sort of legalities of it? How are you guys navigating that?
Absolutely. I mean, it's a great question and kind of related to one of the previous questions. I think for us, evaluation, and hopefully I'd say for anyone building an LLM model that has any sort of risk associated with it, evaluation should be the focus. So for us, the evaluative measures that we're incorporating for the iteration of the LLM includes, you know, going very carefully. I mean, it's a very long process. You go very carefully through the transcript and then you code. Basically, I'm happy to share our coding system with anyone interested. It's very boring, but you code what was the you know, what is the full world of data that was presented in that encounter, and then you create a percentage value and then a number of other sub values of what clinical, logistical, and other data was appropriately translated, and then the goal is for that to be 100%. So we're doing it by essentially looking at those scores, feeding it more prompts, feeding it more conversations generated based on real patient charts, and then checking the scores again, feeding it more, checking the scores again. That's our evaluative process right now.
And then in terms of economics, of, you know, just go to market, I'm assuming that eventually you would like to be sort of B to large B on this, but in terms of all the steps that you need to get before that, when you're validating this model, what's your plan for getting practices on board to be able to try this out? Like, what's the value proposition to them that's being proposed?
Definitely. So for practices right now, actually our pricing model is, so on a provider basis, it's $75 per month. This is based on the fact that each provider, and I have like a chart of this data that's not here, but I'm happy to send it after, but essentially each provider can increase their efficiency based on the idea of saving about 4 to 5 minutes per patient visit, can in high volume settings where they need to see more patients, can increase their efficiency by 33%. That's assuming a 15-minute standard average visit. And so the revenue is expected to increase. There's a revenue potential increase of about 33%. So this price is based on that, where the practice is still keeping a large part of that, margin of increased efficiency.
In that model, are you assuming that the physician is the one doing the intake, or their staff is the one doing the intake?
Yes, we are. So basically it's it varies. So for practices, so our pilot partner practice is a more standard practice, not like the ophthalmology case where they are taking their own, HPI intake history. They are rooming, they're having a nurse room patients, and they kind of collect vitals and a basic kind of chief complaint, but most of the HPI is via the physician. In that case, that's this 5-minute savings from the physician's perspective, and also documentation afterwards since the HPI gets pre-populated. In the ophthalmology setting and in other settings where we're seeing, practices get creative about this here where they have like a tech doing the HPI, it's actually a practice level savings because obviously there's an efficiency gain from the FTE time of the technicians that are hired, and the technicians in this setting, for example, have tons of other jobs. They have to check the glasses, they have to check the prescriptions. They themselves are completely overwhelmed and honestly not trained to do clinical intake. And so, yeah, that's where that comes from.
Perfect. Thanks.
Sure.
All right. Terrific. Thank you, Dr. Kosla, for another outstanding pitch. Well, we've heard from 3 great companies. We'll send our judges off to do some deliberation and come back with a winner. It sounds like we have some themes that developed around basically triage and getting patients to answer questions. Question for you, judges. You have a lot to talk about. What are things that you're going to be discussing in terms of things that impressed you with these pitches?
I really like the taking unique approaches to major pain points and inefficiencies in the emergency department. So giving us a lot to think about.
Yeah, it's given me a lot to think about too. It's fun to see how there's a different take on all of these, of course. And I really enjoy seeing either the graphic or hearing the audio implementation of the company.
That's great.
I really like that all these companies are triple bottom line companies, both in terms of social, clinical, and financial good, and also had really clear articulations of the problem and solution statements.
Yeah, I think for me the biggest thing is the focus on addressing a really big pain point for clinicians all around, right? We see a lot of products that are being developed that maybe people that claim to address burnout amongst clinicians and things like that, but don't necessarily understand what's contributing to it. Whereas I do think that these products are really addressing a known pain point that really would move the needle if effectively addressed.
All right. Well, I'm going to remind our participants, our viewers, the winning pitch team will be offered consultation services with the Stanford Emergency Medicine Partnership Program, STEP, a program that evaluates and executes partnerships between Stanford's Department of Emergency Medicine and external innovators. We're going to drop a link to our recent publication about the group in our chat, which you can access. And now, judges, I will say adios for a little bit, and I'll offer you some time to deliberate, and we'll call you back when you have a decision.
All right.
All right, thank you. And we will reconvene with our judges after they've talked amongst themselves and selected a winner. While they talk, let's all talk with our conference co-chairs, Fran, Andy, and Dan.
Right.
Hi guys. Thank you for letting me borrow the studio. I do like the background you guys got though. I don't know. It's hard to pick a winner here.
Yeah, the red, the cardinal red.
Yeah. Well, certainly we're not doing any of the judging, but just wanted to pick your brains. What did you like about the pitch? Or what are you looking for in a pitch? I should say when you've heard pitches before. What excites you?
I'll go first, if you guys are okay with that. So I think pitching is a very underrated skill because people think of pitching, they think of startups, blah, blah, blah. We have to pitch all the time. I have to pitch my wife why I got to leave today and she had to do childcare, right? Lots of pitching goes on in the world. So I think it's very important. The thing, at least, or if we're going to specifically talk about pitching these type of companies, the one that I really agree with Justin Norton earlier was I want someone to teach me something. Like the best times that I have and when I get the most engaged is when there's some contrarian thing I haven't thought of before, right? That's when you're really going to pull me in. So that's one big thing. And the rest of it, what I'm looking for in a pitch, to be honest, it's really a credibility game. Like most people are going to say great things. It's always up and to the right. And it's really, do I believe what they're telling me? So if I can find those things in a pitch, I'm ready to rumble.
I like that credibility. Well, I can say, as a former engineer and product person, I mean, I think for me, two things. One is, I really want to get at least a high level sense of how it's built and what they're building, and how much they're deciding to build themselves versus off the shelf, and kind of make sure that it's not vaporware. I think there's a lot of thin wrappers around products which end up having very little moat and really don't scale to a vision. And so that vision and kind of MVP and beyond pathway, along with the technical chop, is what I'm looking for.
Yeah, show us the traction, right?
Yes.
Yeah, show us that you've done some work.
Yes.
100% agree with you guys. And for me, I'll say two things. One is I love a good story. So, you know, as clinicians, as doctors, why should we care? What is a problem that we can relate to as doctors at the bedside? And what does your solution do for us? And then number two is I love the team slide. So I love the team slide because, yeah, number one, you know, do you guys have the workflow, the technical operational know-how and the skill sets to solve this problem? But also I love it when people from the C-suite are on a pitch together and then I get to see their chemistry. Because I mean, I feel like when you're in a startup, and I know Dan, you can talk, you can speak to this, you guys are kind of married to each other.
Yeah.
Yeah, and it is not easy to go through the ups and downs of a startup and to be with each other during the worst and best of times. Like I feel like requires a lot of emotional maturity and just really good chemistry and just being there for each other no matter what. So
yeah, I think that was well said earlier in the VC thing when they said team is 1, 2, and 3, and you have to be like very uniquely qualified. We were just talking about this earlier, like finding that team that is like only they are the ones who can do this and they have some huge unfair advantage. Like you find that and like rest of things tend to fall in line.
Yeah. I mean, even in a 7-minute pitch, just the body language, how they talk to each other, the communication styles, it says a lot.
Yeah.
Yeah.
And of course, things like it has to be dynamic, captivating, you know, entertaining.
Yeah. And Dan, you mentioned the VC talk earlier. As a reminder, we'll have our videos available for attendings to rewatch again at a later time, just in case you missed it. You know, obviously you put a lot of work into this conference. What was it about a pitch competition? Like, why do you think it's important to have a pitch competition in this, and especially a live one? You know, a lot of tension here.
Yeah, I love these, and I think that there's a lot of learning that you can get from seeing somebody else going through the process, right? And especially seeing how judges coming from this investor point of view are viewing this, because very often if you're starting a company like I have done a couple times, you like have this singular vision and you're like, everyone must look and feel the same about this problem as me. But being able to see other people and how they're approaching their own problems really, I think, can open your own mind to how maybe you should start thinking about your own issues slightly different. And that's why I think we've included it in here, not just for the entertainment value of it, but really to kind of showcase, like, what does it mean to actually be, you know, that courageous person who's out there trying to do something new.
I think for me, a couple of things. I mean, first of all, you know, we're focused, I think the StEMI X community, many people are focused on kind of really pushing the frontiers of how we practice in acute care. And although there's like differences between the themes of the talks, you know, all of us want to translate some theory, idea into reality that really empowers patient care. And I think the pitch competition in many ways is a synthesis of all of that, you know. So I think there's a lot of like thought-provoking talks and ideas and kind of people talking about the limitations or the killer apps and things like that, and kind of seeing the pitch competition in many ways brings a lot of that together. You know, what is the offering, you know, what is their MVP, and all kind, it has to make sense technically and from a business perspective, really offer value. And I think having that come together at the end was really nice.
Yeah, for me, it just goes back to the people. I mean, I've worked with founders and been an advisor for startups. I've been scouted for startups, and just to see, it takes so much boldness to have a dream, right? And to just force that into reality. I have so much respect for Langsha, for Kathy and Natalia, for, you know, being in front of hundreds of people, right? And the judges, and to share their dream and really try to convince them that this is the problem to solve. And so just so much respect to all of them. That is something that I love about every pitch.
Yeah. I mean, it sounds like you've all had experience pitching companies before, obviously taking care of patients too. What do you think is more anxiety provoking, having a pitch competition, pitching in front of investors, or dealing with that septic hypertensive patient on your second presser? in front of you?
One's an easy one for me.
Yeah. I think so too.
Yeah, sepsis is hard.
Yeah. For people watching, how do you recommend they get involved if they're interested in pitching next year?
Yeah, so on our webpage, StEMIX.live, we actually have a form where you can actually fill out. We actually do a pretty thorough background check of everything that's going on. And once again, like we are focused on the acute care space. So if you're doing some like genomics research that doesn't have anything to do with this, it's probably not going to be relevant. But we'd love to hear from people. As we've mentioned multiple times, we have our own program about bringing things into Stanford as well. So it can be part of that. It can be part of this. So I focus on coming to that to figure out how to be involved.
Also, we're all friendly. So just, connect with us on LinkedIn, right? We want to meet more people, make more friends, and hear from you directly.
Terrific. Yeah. And, again, you've all worked so hard on this conference all day. Thank you so much. What do you think you've enjoyed most about putting this conference together, getting these terrific guests, these sessions? It feels like we've kind of accumulated a lot of different people to come and talk about a lot of, focused talks that some people haven't heard before or been exposed to before.
Yeah, I mean, the exciting thing for me is I've like sat around and listened to the whole conference as we've been here, and like there's many things that I did not know or had not even thought of that I've learned today. There was several things about in our breakout session, which if you didn't get to see, I would recommend you go and see the other breakout sessions and the videos that we'll send in a little while, because there was some amazing stuff that just really opened your mind to the potentials of this technology that's coming.
For me, I continue just to be kind of amazed by the community that we're building. One of my favorite activities is to kind of look through the registrants, try to get a sense of, where people are joining us from. And it's, often with like gathering data or surveys or something, things like that, you kind of see a lot of responses from like the East Coast or the West Coast, but we really have a great representation across the country, Midwest, South, everywhere in between. And then also internationally. We have people from digital health leadership and government from Malaysia and New Zealand. And so I think it's so interesting, as we build this community, kind of the cross collaborations that can happen, because we all know this is a interdisciplinary field that requires, people to come together. So
for me, it goes back to the people again. I mean, you guys are seeing three faces right now, but what you don't see is behind the scenes. We have admin staff who are like Marvel superheroes. They are carrying us. You guys just don't see it. And so to get to know them and see all their hard work in making this conference possible, and getting to know get better know my friends here is the best part of the conference, including you, Rana.
Yeah, thanks. I think you mentioned it, Andy, yesterday. It was like, you finally know what a producer is and what an executive producer is and all these different things it takes to help produce this kind of show. Well, thank you all for joining us. I want to come back to our judges who are rejoining us because it seems like we may have an answer and a winning pitch team. All right, welcome back to our judges. I imagine you've had some tough discussions. Have you selected a winner?
We have. Yeah, all very good candidates. It's a tough decision. Very impressed by everyone, and to some extent solving somewhat similar problems, which was a bit of a surprise. I guess to give some constructive feedback to the team, CyrenCare, we're really impressed by your solution. We think the predetermined questions approach is quite quality, but that sounds like there's some more validation to do on the effectiveness in reduction of times there. Simbie, think that your approach is going to be very successful, leveraging voice tools to drive down onboarding patients, and that the focus on non-emergency patients is a little bit outside of the STEMI application zone, and so for that reason, Vita is our chosen winner. Congratulations.
Well, congratulations, Longsha and the Vita team.
Thank you so much.
All right. Well, we will be reaching out in regards to your prize. Thank you all to all of our participants. thank you to our judges. I hope this is a meaningful experience and wonderful for our audience to view as well. Well, with that, I will be closing Pitch'em, and until next year,